It's an honor and a pleasure to be here to speak to all of you today and to be back in this building and back in this room. I think from the superstar presenters we've had so far, it's become fairly obvious that Medicaid is a multidimensional issue that's difficult to pin down and even more difficult to evaluate. So, how do we begin to determine what Healthy Michigan has accomplished in just less than 3 years? To do that, it's difficult to measure health. Do we stick with the definition implicit in the medical model of care, that health is an absence of any signs or symptoms of diseases? Do we pursue a more grandiose notion of total health, such as the World Health Organization's definition that health is a state of complete physical, mental, and social well-being and not merely the absence of diseases or infirmity? How we define health will change the ways that health outcomes are evaluated. Moreover, with fewer than 3 years of Healthy Michigan behind us, our expectations of immediate gratification need to be tempered by the temporal realities of the program. Health improvements take time. Recovery from years without health care takes time. Adopting new healthy behaviors and better self-management of health also takes time. Nonetheless, we do have some early evidence of program outcomes. Firstly, we have enrollment numbers. The more than 600,000 Healthy Michigan beneficiaries are not only the principal program output, but also evidence of the utilization upon which any health outcomes must be predicated. Moreover, some studies reveal that beneficiaries tend to self-report better health from expanded Medicaid. In other words, we know people are using the program, accessing care, and we know they're generally happy to have it. Wary and Miller, publishing in the Annals of Internal Medicine, found that there were significant increases in respondents reporting diagnoses of diabetes and high cholesterol. The incidence of diabetes was also found in the previously mentioned Oregon study. And this has echoed results in other studies. The increased detection of chronic health conditions under Medicaid expansion could have important implications for both population health and state and national healthcare spending if it leads to improved early management and control of these conditions. Acquisition of insurance may facilitate better use of health screenings and preventative health services, leading to early treatment, providing important long-term health benefits. Beyond diabetes and high cholesterol, Healthy Michigan beneficiaries may access mammography, screening for hypertension, and other services to prevent or detect sometimes asymptomatic chronic conditions. An initial fear prior to implementation of Healthy Michigan was that there would not be available capacity among medical providers to treat a sudden influx of newly insured individuals. And as we've already heard, this problem didn't materialize. Tipranani et al. Publishing in the American Journal of Managed Care this year, or rather last year, 2016, found that 1 year following Medicaid expansion in Michigan, appointment availability for new Medicaid patients actually increased. Furthermore, median new patient wait times remained within 2 weeks, with more than 95% falling within the 90-day requirement of the Healthy Michigan law. This is perhaps attributable to increased proportions of appointments scheduled with non-physician providers. Previous research from the Citizens Research Council concluded that care provided by NPPs, that is, nurse practitioners or physician's assistants, within their scope of practice was technically comparable to care provided by physicians and sometimes yielded greater patient satisfaction. As Amy mentioned, children were previously covered by CHIP in the state and not the intended beneficiary group of Healthy Michigan. Nonetheless, children living in Medicaid expansion states like Michigan had nearly double the rate of improvement in their uninsured status as children in non-expansion states. Previous research has found that children's uninsured rates decline when their parents are offered coverage. Parents with health coverage who engage in positive health behaviors are also more apt to pass those on to their children. Michigan's always been an innovator, and Healthy Michigan is no exception. We've already heard about the cost sharing included in Healthy Michigan and healthy behaviors that is hoped to incentivize. Problematically, collection of cost sharing may not occur due to providers declining to write off copays for Medicaid patients or due to the administrative complexity of MCOs collecting these fees. How effectively the change in benefit structure of Healthy Michigan is achieving the goal of improved health status and moving people into private care still remains to be seen and requires further analysis. Collection issues surrounding the cost-sharing provisions should be considered in future evaluations of Healthy Michigan's success. Likewise, we need further evaluation of emergency room usage for ambulatory care sensitive conditions. In other words, things that would be better taken care of at a physician's office. The uninsured seldom obtain preventative health and wellness services that can substantially reduce the incidence of morbidity and mortality. Medicaid expansion helps to close coverage gaps, dramatically reducing the uninsured population and increasing the use of preventative care and services, including behavioral health. Medicaid expansion improves self-reported health in some studies, though results are admittedly mixed, possibly owing to some individuals feeling less healthy following a diagnosis of a chronic condition, even if management of that condition will lead to better health in the long run. Beneficiaries have already also reported missing fewer days from employment, alluding to tangential economic benefits from a healthier, more productive workforce. Having coverage reduces stress and improves mental health and reduces depression. These are important health benefits that are tied to many other chronic conditions and some of the leading causes of death in the United States. Evaluations that consider only health outcomes relating to morbidity and mortality fail to recognize that Medicaid expansion coverage dramatically increases financial stability for individuals and families. Homeowners insurance isn't purchased to prevent theft or fire, but rather to avert financial stresses of bankruptcy that may occur when these catastrophes happen. Similarly, health insurance can't be expected to completely end the need for healthcare services and utilization, but rather it averts financial ruin when catastrophic circumstances or diagnoses do occur for beneficiaries, helping each beneficiary continue to function as a productive and hopefully tax-paying citizen. If the value of healthy Michigan is to be weighed against its costs, this economic betterment should not be overlooked. As Dr. Martin mentioned, the fact that some states decline to expand Medicaid gives us a good point of comparison for evaluation. We know from the State Health Reform Network, a program of the Robert Wood Johnson Foundation, that expansion states saw smaller increases in state Medicaid spending. Expansion states saw more job growth in the health sector. In 2014, the first year of implementation, expansion states saw an overall decrease in uncompensated care of 26%. In Michigan, as we heard, that's up to around 50% now. The climbing rate of insured patients in expansion states is helping to stabilize struggling hospitals, particularly rural facilities. Rural hospitals are twice as likely to face closure in states that did not expand Medicaid. Researchers at the Georgetown University Health Policy Institute found that compared to non-expansion states, states that have expanded Medicaid have seen major reductions in uncompensated care delivered by safety net institutions, significant drops in the number of uninsured residents, and budget savings for hospitals and community health clinics. Health executives in Medicaid expansion states report opening new clinics, buying new equipment, and hiring new staff, all of which allow them to begin filling in the current health system and work to actively integrate and improve the care they deliver. By contrast, health executives in non-expansion states say they continue to face substantial financial pressures and are more likely to pursue status quo operations. Expansion had significant fiscal effects on state budgets beyond just savings in Michigan, with savings ranging from $25 million in Kentucky to over $100 million in Washington state. Admittedly, that's mostly due to the federal windfall of matching funds under the Affordable Care Act. Expanded Medicaid was intended as a crucial mechanism to avoid coverage gaps in the Affordable Care Act. It's the means to provide coverage when systems of employer-based health insurance break down due to cost, typically among low-wage workers. As one might expect, states that expanded Medicaid have largely eliminated gaps in coverage, whereas states that chose not to expand Medicaid still have large numbers of uninsured individuals. So, what's next? That's a tricky question. There's still a great deal of uncertainty regarding the future of Healthy Michigan and the Affordable Care Act. Possible changes at the federal level by the new Congress and incoming Trump administration may change the ballgame. So what can we all expect going forward? It's still difficult to say with any certainty. In one possible, albeit I think unlikely scenario, federal funding for Medicaid expansion could be eliminated entirely through an ACA repeal with no corresponding replacement provisions, explicitly ending the program. Some Healthy Michigan beneficiaries, such as disabled individuals, could transition back to traditional Medicaid at a higher cost to the state, but most beneficiaries could not. Losing both Healthy Michigan and ACA private insurance subsidies, the state would need to decide how to provide coverage, if at all, to aid the combined nearly 1 million newly uninsured residents. Michigan would need to look for ways to do so more efficiently and more effectively to combat the multi-billion-dollar price tag on Healthy Michigan, or else we would need to generate additional state revenue to support health coverage for state residents. In another scenario that's received support from the incoming Trump administration, funding that Michigan receives from Medicaid may shift from the current categorical grant funding to a block grant. I know Steve is going to talk about this when I'm finished, so I'll reserve my comments and just say that block granting does have some drawbacks. Funding, for instance, would be unlikely to keep pace with inflation, let alone the growing cost of health care, and it's a significant drawback for the state budget. Given decades of continued growth in health spending, it's unlikely that funding levels of block grants would match program needs in this scenario without aggressive state action to limit spending over time. Perhaps it's best to say that by enabling new approaches not previously allowed under CMS rules, block granting of Medicaid offers Michigan equal opportunities for either success or failure. Another possibility is the expanded use of health savings accounts, or HSAs. It's a preferred policy solution currently that, if subsidized through state and federal funding, could be offered not only to beneficiaries of individual health exchange plans, but theoretically also to Healthy Michigan beneficiaries whose incomes are above 100% FPL. Without significant state investment to subsidize plans, as with the My Health savings plans, however, this approach would not likely be feasible for low-income adults. An HSA, of course, is a tax-advantaged Medicaid savings account, allowing individuals to save pre-tax earnings to cover the cost of future care, and is intended to be paired with a high-deductible insurance plan for catastrophic coverage. The HSA attempts to rectify the inherent market failure present in third-party payment systems like the one we have by exposing patients to the true cost of care. No longer shielded from these costs, HSA account users will theoretically be able to make more informed decisions about the benefits of their care relative to its cost. Research has indeed shown that HSAs successfully reduce unnecessary utilization of care. However, the HSA seems to also lead to individuals sometimes foregoing needed care due to cost. The risk of deciding to forego needed care seems to be greater among low-income individuals, such as Healthy Michigan beneficiaries, as does the risk of insufficient HSA funds to cover needed care. So, what do policymakers need to know as we go forward, or perhaps what do we need to acknowledge to move forward, as Michigan will likely need to assume greater responsibility for the health of its residents? The U.S. is the only advanced nation that does not guarantee access to basic health care for all citizens. Years of expensive care and high rates of uninsurance have led to poor health behaviors, poor management of chronic conditions, in turn leading to more cost. In the U.S., we spend more on health care, both in per capita dollars and as a percent of GDP, and yet achieve only mediocre health outcomes from this spending, as evidenced by measures of population health, such as shorter life expectancy and higher rates of infant mortality relative to other advanced peer nations. The high cost of health care affects Medicaid in a variety of ways. Firstly, as more people are priced out of private insurance, they become reliant on Medicaid to pay for their care. Additionally, when we frequently say that Medicaid has low reimbursement rates, we're making a valuation based on the current cost of care that is much higher than it was 52 years ago when Medicaid was adopted. In 1970, people in the United States spent an average of $341 per person per annum, 7.1% of GDP. By 2009, at the adoption of the Affordable Care Act, spending was at $8,200 per person per annum, totaling $2.5 trillion in the U.S., 17.3% of GDP, and this number has continued to grow since that date. It's the opinion of the Research Council that if we're going to spend more of Michigan's limited public resources on health care, necessarily taking resources away from other essential state services, we need to spend our resources wisely and in a purposeful way. One option may be higher emphasis on marginal cost and marginal effectiveness considerations to improve the efficiency and efficacy of care. This aspect of well-managed healthcare systems is often overlooked. Though emphasis on prevention and preference given to efficacy of drugs relative to cost, it is possible to achieve better care at a lower cost by allocating funding in purposeful ways. We've resisted this approach in the U.S. so far. The Affordable Care Act expressly prohibited the use of monetary unit per quality adjusted life year, a commonly accepted metric in determining cost effectiveness of care. The Heritage Foundation, for instance, has also called comparative effectiveness research a slippery slope to rationing health care. Some may say that this is rationing of care, and they're probably correct. I would encourage these people, however, to further recognize that health care might be understood as a limited resource. Its availability is constrained by the number of healthcare practitioners and facilities we have, by resources available for providing care, such as medical equipment or pharmaceuticals, and by the percent of our fiscal resources that we're willing and able to dedicate to pay for more health care for our citizens. The U.S. healthcare system has always rationed care in a way. Demand-side or price rationing has occurred wherein healthcare has been rationed solely on the basis of ability to pay and without regard to the effectiveness or value of care to the individual. Choosing to leave this aspect of U.S. healthcare and Michigan healthcare, therefore, is still a decision on how we should ration care. It's a default one. As we create programs like Healthy Michigan or future as yet undetermined replacements that extend care to more individuals, we need to contend with the fact that we're either going to be increasing overall spending and costs, or we have to face the challenge of utilizing health care resources more effectively to maximize the marginal benefit of each healthcare dollar spent. Until we break the taboo on cost-benefit analysis and comparative effectiveness research in healthcare, we'll continue to spend more to achieve poorer health. Until we recognize that rationing of care may be inevitable as we extend care to all of our citizens, and that accepting the status quo is to accept rationing on the basis of price rather than need or marginal utility, we will allow costs to price more people out of care rather than targeting health services to achieve the greatest positive health impact.